Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Ryan Topping. Today's episode features an expert discussion focused on key factors that inform the selection of regorafenib and TAS-102 as later-line therapy options for patients with metastatic colorectal cancer. This episode is part of a larger program consisting of a podcast series focused on treatment options for patients with colorectal cancer. During this podcast, Dr. Chiara Cremolini from the Tuscan Tumor Institute in Pisa, Italy, and Dr. Teresa Macarulla from Vall Institute of Oncology in Barcelona, Spain, discuss key predictors of improved outcomes with regorafenib versus TAS-102, individualization of treatment, and the importance of timely transitioning from second to third line therapy for patients with metastatic colorectal cancer. Please visit the show notes for this episode for a link to the complete program, including downloadable slide sets and additional coming expert podcasts. Now let's get started and hear what Dr. Cremolini and Dr. Macarulla have to say on this important topic.
Hello, my name is Teresa Macarulla. I'm GI medical oncologist, the head of the GI unit here in Vall Hebrón in Barcelona. And today it's my pleasure to be here with Chiara Cremolini to discuss the situation of colorectal cancer treatment in third line. Chiara, hello.
Hello, everybody. I am Chiara Cremolini. I am a medical oncologist at the University Hospital of Pisa. I'm mainly interested in GI cancers, and I'm happy to discuss with you and to share some considerations about this topic.
First of all, in the last decade, we have these two options in third-line treatment in advanced colon cancer. So we have two options. How you decide, Chiara, in your daily clinical practice, which is the best treatment, regorafenib or TAS-102 for your patients?
This metastatic colorectal cancer patient that has already failed the most conventional treatment options, including 5-FU or capecitabine, oxaliplatin, irinotecan, anti-angiogenic agents, anti-VEGF, and anti-GFR in the case of RAS and BRAF wild-type tumors. In particular, I think that both of these options are quite convincing in terms of the level of evidence that has been provided. In both of these cases, we do have a positive and repeatedly positive phase 3 trials. In both of these cases, we do have trials investigating the efficacy of each individual drug as compared with the placebo, while we do not have a head-to-head comparison. So we just need to rely on our good clinical sense to offer the best treatment option for each individual patient. For example, I generally go for regorafenib in patients who are not too old, that have not a severe liver impairment, because as you know, regorafenib is mainly metabolized by the liver, and an increase in bilirubin and transaminase is one of the most frequent adverse events in terms of lab abnormalities. And this is the reason why, in front of a severe impairment of the function of the liver, I generally do not offer this option. On the other side, I generally go for TAS-102 for those patients that have not optimal general conditions. In the case of optimal general conditions, I generally go for regorafenib. And in those cases that have reported not severe chemo-related toxicities with the previous chemo regimens. So I generally offer the best choice based on patients' general conditions, ECOG performance status, and the liver impairment. These are the main drivers for my choice. How do you do in your daily clinical practice, Teresa?
Yeah, I think these two drugs present a different safety profile, and this is something that for me it's crucial in order to decide in which patient I have to use one or the other. No, for example, if one patient presented some uncontrolled hypertension, maybe it's better to give TAS-102. But if a patient presented some hematological toxicity with the previous regimen of chemotherapy, I tend more to give regorafenib. And also I have in mind that when in the pivotal trial with TAS-102, they demonstrated activity after regorafenib or not. So that's something that sometimes helped me to say, okay, I will try to start sometimes with regorafenib and then we can go to DAS 102, but it depends on the side effects. I completely agree. And then we have another important point, especially in regorafenib. I think in DAS 102, we tend to start with full dose, no? Because then we have the problem with hematological toxicity and we see how we can manage the dose. But then in regorafenib, it's different. So we have some trials, no? For example, the rearranged trial or the redose trial that raise the question, we have to start with full dose, we have to start with reduced dose and increased dose, which is your clinical practice.
Well, I think that the results of these redose and the rearranged trials have been crucial to optimize the use of regorafenib in the daily clinical practice, because many physicians, many clinicians were quite worried about the safety profile of regorafenib when given at full dose, 160 milligram per day. Instead, adopting some flexible escalating dose strategies, the toxicities may be significantly reduced, and also the compliance and the adherence to the treatment may be much better. This does not impair the efficacy of the treatment, but on the other side, it allows to preserve patients' quality of life, thus making the adherence to the treatment more efficacious in the daily clinical practice. So this is the reason why I generally start with 80 milligrams per day, and then I escalate at the second week based on the patient's adverse events. I think that starting with 80 milligrams per day and then escalating on an individual basis is a good strategy to be adopted in a daily clinical setting scenario.
Yeah, I completely agree. We participate in the rearranged trial, and we demonstrated that when you started with lower dose or you increase progressively the dose, the efficacy is comparable with the standard dose at the beginning. And always it's better to increase than to decrease the dose, no? And also, I think another important point here is when we start with regorafenib, we have to closely follow our patients. So to visit the patients every 2 weeks or to be there just in order to see how is the toxicity, because sometimes there are some patients that tolerated very well the drug, and there are some patients that presented this fatigue, this diarrhea, this hot and foot syndrome. So I think it's important to be there, to be close to the patient at the beginning of the treatment. Another point that we have is we don't have biomarkers, so we don't know which are the best patients for these treatments, but we have these trials. For example, in regorafenib, we have this retrospective data from Italy, the reality trial, in which they try to describe the best patients or the patients with better outcome. And then we have with DAS 102, we have this post hoc analysis, the pivotal trial, in which they try to describe this population with better outcome. No? Which is your opinion? Do you have that this help us to decide which is the best patients to be treated with these drugs?
I think that especially with regard to regorafenib, the information provided by the reality trial is quite important, in my opinion, because this concept is strictly related to what we have previously discussed about the starting dose of regorafenib. So starting the treatment of these patients from a lower than initially established dose, 80 milligrams per day. Indeed, in this trial, which is a retrospective analysis, an observational study of patients treated with regorafenib in the daily clinical practice, the authors point out that respecting the dosing initially planned and not having too much dose delays or treatment reduction is associated with a better clinical outcome. And in my opinion, this highly underlines the usefulness of starting the therapeutic route with 80 milligrams in order to avoid treatment delays or interruptions that may definitely impair the efficacy of the treatment. On the other side, I think that for both of these drugs, it is very important to stress the concept that we cannot wait too much before treating our patients. I mean, it is not useful to offer a lot of chemotherapy retreatments and the rechallenge and the reintroduction of chemotherapy, especially when previous progressions have occurred under the treatment while patients were on treatment, because these chemo rechallenge are often completely not useful, and the risk is to have a deterioration of patients' general conditions and ECOG performance status that prevents from properly exploit these options for advanced lines of therapy. In other words, in all of these retrospective analysis, we clearly see that the highest is the ECOG performance status, the highest is the number of previous lines of treatment, the lower is the efficacy of these treatments. And so I think that the message is to properly use these options when it is not too late in the treatment history of our patients.
Yeah, I agree that probably our recommendation is to use these drugs in a pure third line, after the first and second line to progress the standard therapy, but a pure third line. I agree, just in order to avoid more toxicity that then can make more difficult to give these drugs, regorafenib or TAS-102. So, well, thank you very much. Maybe you can give us, Chiara, your last key message of the third line treatment in this advanced colon cancer.
I think that in third line therapy of metastatic colorectal cancer, the aim of the treatment is definitely palliative. In the next years, we will probably have available for the routine use some targeted approaches for small subgroups, but for the vast majority of patients, we still do have efficacious options. Both trifluridine, tipiracil, and regorafenib showed significant improvements in terms of overall survival. So in the case of patients that need to be treated, are demanding an advanced line treatment, and the patients that are in good general conditions, I really do not see reasons not to try with these drugs to improve their duration of life while preserving their quality of life as better as possible by properly managing the adverse events.
Thank you so much, Chiara. I think that's great, especially focusing in this is a refractory population, so be careful with the quality of life. And with this, we have to finish here. I hope you enjoy with the discussion, and it was a great pleasure to be here with Chiara Cremolini. Thank you very much.
Thank you very much, Dr. Cremolini and Dr. Macarulla, and thanks to you, the listeners, for joining us. As a reminder, to view the full program and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show note. As always, thanks for listening.